If you're a fan of the movie Scarface, like I am, then you know that Tony Montana died in a big gun battle. But you have to wonder, if the gun battle hadn't gotten him, would the drugs have gotten him? Now, Tony's drug of choice, of course, was cocaine. And it's hard to imagine a more perfectly designed drug to cause cardiotoxicity than the drug cocaine. It does so many bad things. It blocks ion channels and can cause life-threatening dysrhythmias. It has direct myocardial toxic effects and can present with an acute myocarditis. It causes long-term cardiomyopathies, but it can cause a short-term immediate cardiomyopathy like Takotsubo's. This has been well described in the literature also. Cocaine is associated with aortic dissections in the IRAD, the International Registry of Aortic Diseases, the largest published study of aortic dissections. 2% or almost 2% of them were associated with the use of cocaine. That's a surprisingly high number. So we need to think about all sorts of bad things with cocaine. And of course, as we all know, cocaine can cause an acute myocardial infarction. My talk today is about cardiotoxic drugs of abuse. My name is Bert Bessinger. I'm an emergency physician. I'm also an associate professor of emergency medicine at Indiana University. We're going to be talking about a few different cardiotoxic drugs. We're going to be talking about street drugs, not pharmaceuticals that someone might overdose on that can affect their heart. Focus on a few different street drugs that can have significant cardiotoxic effects. I'd like to point out that I don't have any conflicts of interest, I don't have any ownership stake in anything, and I don't take any money from industry. What I do is I see a lot of patients with cocaine-associated chest pain. This is something we see all the time. We see this very frequently in our emergency department. It's probably the most common thing we see related to abuse of cocaine. One of the reasons for that is that chest pain is a symptom of cocaine use. Could chest pain in a cocaine user be a myocardial infarction? Absolutely, and we have to worry about that. But it's also sometimes just a symptom of the drug. Someone does a little cocaine, they get that rush, they get that euphoria, they get that hyperstimulation, and often they will get an abnormal feeling in their chest. This can be disconcerting, so they will present to you saying, hey, I did some cocaine, I'm having some chest pain, I'm worried that I could be having a heart attack. Is that worry warranted? Absolutely. We know cocaine is associated with acute coronary syndrome. So how often then do these patients rule in for an MI? The number's lower than you might think. It's only about 5%. It's clearly a risk factor, but only about 5%, if you take an average of the literature, will rule in for myocardial infarction. Now, that number's a little bit higher than you might expect if you think about the fact that many of these patients that we're seeing are younger and otherwise healthier than our typical acute coronary syndrome patient. So it's a risk. How does it happen? How does cocaine cause that myocardial infarction? We all learn this in medical school. When I ask my residents, my students, they all immediately tell me cocaine causes an MI because it causes coronary artery vasospasm. True, it absolutely does that. Interestingly, there have been a number of studies looking at this in cath labs where they're doing a heart cath on a patient, like an elective heart cath. They enroll them in a study where they expose them to some cocaine during the catheterization procedure, and it has been demonstrated that yes, cocaine does indeed induce some coronary artery vasospasm. Interestingly, it doesn't usually completely occlude the artery, but it does significantly decrease its cross-sectional diameter. So cocaine does this. How does it do it? Cocaine acts on many different ways on the heart, as I alluded to at the beginning of the talk. The main mechanism of action that is of concern to us is that it blocks the reuptake of norepinephrine, causing that hyperadrenergic state. So here we have a schematic. You can see here we have a presynaptic vessel, or presynaptic nerve. It's got all these little vesicles that are filled with norepinephrine. It releases them into the synapse. And once those little molecules of norepinephrine are released into the synapse, they can do a few things. They can stimulate a receptor, they can be broken down by metabolism, or they can be taken back up into the presynaptic nerve for reuse. Cocaine blocks that process. So you end up then with an excess of norepinephrine at the synapse, causing that adrenergic stimulation. That's the main mechanism of action we need to be worried about with cocaine, and it's what causes so many of the effects that we see. But that's only part of the story. Yes, cocaine causes an MI by inducing vasospasm, but it doesn't do it by inducing vasospasm alone. It acts in many different ways. So the other side of the equation is that it increases myocardial oxygen demand. Of course, this makes sense. Cocaine causes a hyperadrenergic state. You get peripheral vasoconstriction. Blood pressure is going to go up. Afterload goes up. The heart is working harder. At the same time, the heart's being stimulated to beat harder, to beat faster. You have now increased significantly your myocardial oxygen demand. So we've set up a mismatch here, right? We have myocardial oxygen perfusion decreasing because of coronary artery vasospasm. At the same time, we're asking the heart to do more. We have an increase in myocardial oxygen demand. That is a setup for myocardial injury. But even that is not the whole story. Cocaine does other things. For example, it induces a hypercoagulable state. Does this, we think, in a few different ways. One of the ways it does this is it makes platelets stickier. So some patients that you will see with a cocaine-associated MI will not just have the vasospasm increased demand mismatch, they will actually have a clot in a coronary artery owing to the hypercoagulable effect of cocaine. Multifaceted here. In the long term, cocaine also accelerates atherosclerosis. So people who have used cocaine on a regular basis for a long time are more likely to have underlying coronary disease. There's probably many mechanisms involved. Some of it is probably just a repeat exposure to very elevated blood pressures over time. There's probably also a pro-inflammatory effect leading to vascular injury, leading to plaque formation. But regardless, cocaine accelerates the process of atherosclerosis. And that is important as we start to get into our workup for cocaine chest pain patients. They're not a monolith. There are many different presentations and types of patients that we're going to see with cocaine chest pain, and they each require a little nuance in the way that we approach them and work them up. I think it is incredibly helpful to think about two different big kinds of patients. So first patient, I'm going to call him patient number one, and I'm going to say him because cocaine use is predominantly among males. Patient number one, this is the party boy. This is the 23-year-old kid that's at a party. Maybe he's never even done cocaine before. He's had a few drinks. He's around some new people. He's feeling adventurous. Someone hands him cocaine. And it's a nice party, right? So it's, it's on a nice mirror. There's a $100 bill, the whole thing. Does cocaine. Whoa, never done it before. And boom, I feel like I've got an elephant sitting on my chest. So that patient sitting in your emergency department, that patient, that young, healthy 23-year-old, is not very likely to have underlying atherosclerotic coronary disease that is going to put him at a higher risk. Could he be having a myocardial infarction? Could he be having an acute coronary syndrome? Absolutely he could. Absolutely he could. But it's a lower risk patient because he hasn't had that process of accelerated atherosclerosis due to chronic use, and he's an otherwise young, healthy person. That's patient number one. Patient number two, this is the guy I like to call the old pro. Patient number two is 50 years old. He has been doing cocaine since he was 25. He does it at least weekly. He has kind of gotten used to this process. He has done a lot of cocaine in his life, and he's a little bit older. Patient number two bothers me a lot more for a couple of reasons. One, like I said, he's the old pro. He knows what happens when he takes cocaine. He knows that it can sometimes cause a little discomfort there. He doesn't come to the emergency room every time he does cocaine and gets a twinge in his chest. The fact that he's here today makes me worried that something different is going on. But maybe even more importantly, he has a much, much higher risk of having underlying coronary disease before he even did this most recent cocaine. So he is a much higher risk patient and probably deserves a little bit of a bigger workup. I think keeping those two distinct kinds of generic patients in mind will be helpful. So let's get into the workup a little bit. So the emergency department workup, the initial stuff, the tests we order after we see the patient, we do our history, we do our physical, we go order our workup, is going to be largely the same as it is for all patients that we see with chest pain. We're going to get our EKG, of course, we're going to get our chest x-ray, whatever other labs you like to get, and then we're going to get cardiac markers. We're going to get that troponin. Now, I think this is an area where maybe it differs a little bit from most chest pain patients we see, and that is in the younger patients. So I don't know about your practice, but I think most of us, if we see a young, healthy 20-something who comes in with chest pain and has a normal-looking EKG, unless there's some really unusual extenuating circumstance, most of us aren't routinely checking cardiac markers on that patient. But if it's a 22-year-old who just did cocaine and is having chest pain, yes, absolutely. You've got to get that troponin. So in that way, it's a little bit different. But otherwise, pretty much the same workup. And when we get that workup back, clearly, if we see a STEMI or we see clear evidence of acute coronary syndrome, we're going to get our cardiology colleagues involved, and we're going to get that patient taken care of. The conundrum and the area of some controversy and debate is, what do we do if our initial workup is normal? So we get that EKG back, and maybe it shows that they're a little tachycardic, but otherwise it looks normal, and we get that troponin back, and it is normal as well. Now what? Are we done? Do we need to keep going? How far do we need to take this? Well, there are some guidelines, but I will tell you they're a bit dated. The most recent comprehensive guidelines from the American Heart Association for cocaine chest pain are now well over a decade old. They were published in 2008. Now, there have been some allusions to cocaine chest pain in more recent generic guidelines about acute coronary syndromes in everybody, but the last really comprehensive guidelines were from 2008. And this is what they say. They say, listen, cocaine chest pain, that's a high-risk situation. We recommend that you keep those patients overnight, that you put them, for example, in a chest pain observation unit. And while they're there, they should get serial troponins to rule out myocardial infarction. They should have serial EKGs. And you should consider then doing further testing, something like a stress test in these patients. So these are the guidelines that we have. Things have changed since 2008. Our approach to chest pain patients in general has really been revolutionized by a number of things. We admit far fewer of these patients than we used to, and our workups tend to be a little bit less aggressive. So can we apply that to the cocaine patient? I will pause here and say we're in a little bit of an evidence-free zone. This hasn't been well studied, so we're going to extrapolate for some other data and talk about how we might, in a rational, resource-smart way, work up these patients with cocaine chest pain. And again, it's critical to think about our two different kinds of patients. Not all patients are the same. So patient number one, remember, this is our 23-year-old party boy, never done cocaine before, did it, got this squeezing sensation in his chest. So it would certainly be very reasonable to do at least another troponin. We get the initial troponin back, it's negative. We're going to, of course, repeat a second troponin in this patient. Absolutely, probably reasonable to repeat a second EKG. Down the road, further testing with things like a stress test, probably not necessary or helpful in this patient. Again, think about it. 23-year-old guy, he doesn't have underlying coronary disease, or almost certainly doesn't have underlying coronary disease. So unless there's something very unusual about this patient, probably does not need ultimately to have that stress test. Do we need to keep him? Probably not, although I don't have robust data to share with you to tell you definitively not. It would seem, given the context of the way we work up patients with chest pain in general, and given the context of, yes, this person could be having an acute coronary syndrome right now because of the effect of cocaine, but probably doesn't have a plaque in a coronary artery, that once we've ruled out that immediate acute coronary syndrome with things like troponins and EKGs, that patient, I think, is reasonably discharged home, and most of us incorporate this kind of practice into the evaluation of these patients. So that's patient number one. Probably doesn't need to stay, needs careful workup. I should put a caveat on that, though. When I say okay to send home after a couple of troponins that are normal, after normal EKGs, that is under the assumption that that patient's vital signs, for example, have normalized, that his symptoms are controlled, that his pain is gone, and then that patient could reasonably be discharged home. Patient number two, again, this is a higher risk patient. This is our 50-year-old chronic cocaine user. Very reasonable, given this patient's higher risk, to bring him in for an overnight observation in a chest pain unit if you have one, or admit him to the hospital, rule him out with serial troponins, and further testing would seem reasonable in this patient. In the setting of cocaine, there have been some things studied. Just perfusion testing, stress echocardiography, even CT coronary angiograms have all been studied in this patient population. And a negative study here portends a very excellent outcome. So they could really safely be discharged home after something like this. So probably reasonable to consider for these higher risk patients. Now, as I mentioned, things change. Chest pain workup now and the way we disposition these patients, much, much different than it was a decade ago. Can we use some of these newer tools that we use in other chest pain patients with our cocaine chest pain patient? So one example would be decision instruments, like the heart score. So there are several of these now. I'm sure we all use them in our daily practice to help us risk stratify the chest pain patient. The heart score, not necessarily better than the others, but seems to be the one that's become most widely adopted. Can we calculate a heart score and use that in isolation to send our patient home? Based on the one study that's looked at this, probably not. So just to refresh everybody's memory, the heart score, it's an acronym. It stands for history, EKG, age, risk factors, and troponin. And the patient gets a certain number of points for each of those things, and a score is calculated. A score of 0 to 3 is generally felt to be low risk, and in our non-cocaine chest pain patients, we generally let those patients go home for further outpatient evaluation. Can we use this in patients with cocaine chest pain? This is a study that was published in American Journal of Emergency Medicine just last year, and it looked at this, but it looked at it in a bit of a retrospective way. So it's not a perfect study, but it's what we have, and I think it's interesting. So they compared major adverse cardiac events following emergency department evaluation for chest pain in patients who had just recently done cocaine versus patients who had not done cocaine. And as we would expect, based on everything we know about the heart score, the non-cocaine patients with a score of 0 to 3, their risk of MACE was incredibly low. It was 4% in this study. So very low risk patients indeed. The cocaine chest pain patients, though, interestingly, had a much higher risk. This number surprised me as high as it was, but their major adverse cardiac event rate risk was 14%. So this tells us that as it stands, we really can't use the heart score, certainly not in isolation, as a sole determinant to send a cocaine chest pain patient home. We've got to consider other things. The heart score doesn't seem to work here. One of the reasons for that is the R in this acronym, risk factors. It really only includes the classic cardiac risk factors, things like smoking, hypertension, diabetes. Cocaine doesn't get you any points whatsoever in the heart score. So it doesn't really accommodate or account for these patients very well. So a heart score is probably not as helpful here. What about the new high sensitivity troponins? Shorter answer is no idea. There's really not anything in the literature looking at this for the emergency department evaluation of cocaine chest pain patients. But it's something we have to contend with, because if I would have asked the question 5 years ago, certainly 10 years ago, hey, who's using high sensitivity troponins? A couple of hands might have gone up. I ask it today, and I'm going to see a lot of hands go up. Most people either have high sensitivity troponins in their emergency department, or they are getting them soon. So how might this impact our evaluation of cocaine chest pain patients? Again, we don't know. It's not really been looked at, but one has to think it will make things in some ways a little bit easier for us. Because if we were already getting to the place where in the low-risk patient, we felt comfortable sending that patient home if they had serial negative troponins in the emergency department, normal EKG, symptom control, vital sign control, and letting them go home, we would feel even more strongly about that if they had negative high-sensitivity troponins. Now, the potential downside of this, again, we don't know, just hypothesizing here. Cocaine, again, makes your heart beat like crazy, increases your myocardial oxygen demand, increases your workload. Could that result in some troponin leak that's going to give us some false positives that are going to make things more difficult? Absolutely possible. There was one study that looked at asymptomatic cocaine users, and they did not seem to have a bump in their troponin. But again, we really don't know how this is going to play out. All right, so that's our workup of the cocaine chest pain patient. Let's talk for a few minutes about how we treat them while we're dealing with them in the emergency department. And again, much of this is mostly the same. I'm going to pause here for a second just to say this, again, is an area where there is not incredibly good data. Not a lot of randomized controlled trials looking at treatment for cocaine chest pain or for cocaine-associated acute coronary syndromes. There are a couple. We're going to talk about them. But most of what we do, we've extrapolated from a few other areas. We've extrapolated greatly from how we treat normal acute coronary syndrome, not related to cocaine, and have just adopted that to the cocaine acute coronary syndrome. We also, interestingly, I mentioned earlier that they did some studies where they went to the cath lab, gave some cocaine, observed the coronary artery vasoconstriction. There are also a number of these studies. Most of them were done back in the 1980s, where they had the patient in the cath lab, they gave the cocaine, they watched the coronary artery spasm, and then they gave them another drug to see what happened. Did this drug make it better? Did it make it worse? Did it have no change on it? So some non-patient-oriented physiologic data also informs what we do. We don't know if that really means anything, if it reverses the coronary artery vasospasm a little bit, but it seems like a good thing. And then lastly, just from the toxicologist, how do they like to treat cocaine intoxication in general. That informs what we do. So our initial treatment, like we see the patient when they walk in the door, what are we going to give them for their cocaine-associated chest pain? We're going to do the basic stuff. We're going to go ahead and give them an aspirin. Again, not great data on this in cocaine chest pain patients, but we know it makes platelets stickier. Seems like a very reasonable thing to do. If they're having a lot of pain, nitroglycerin would also be reasonable. So same kind of thing. If we get that EKG back and it shows a STEMI, we're going to treat it like a STEMI. Again, we have vasospasm, increased demand, but we also sometimes have thrombus in the coronary artery. So they're going to get the usual cocktail of antiplatelet drugs, anticoagulants, and they are going to go off to the cath lab. So that's all the same. Doesn't matter if it's cocaine, not cocaine. But there are some things about treating cocaine chest pain that are different than the way we handle our non-cocaine chest pain patients. One of them is the use of benzodiazepines. Cardiologists, they love to drive Benzos. I don't very often see them prescribing Benzos, certainly not for their chest pain patients. It's not something we routinely use in chest pain. We're going to rely heavily on it in cocaine-associated chest pain. Then there is the question of beta blockers. Do we use them? Do we not use them? A little bit of controversy. We'll get into that. So benzodiazepines. Benzodiazepines are the cornerstone of treatment for cocaine intoxication in general. They just slow everything down. They blunt that sympathetic surge. They bring down heart rate. They bring down blood pressure. They decrease psychomotor agitation. They do a number of good and probably beneficial things in the patient with cocaine in general, and those things would theoretically be of benefit in the patient having cocaine-associated chest pain as well. Again, bringing down that myocardial oxygen demand by slowing down that heart rate, bringing down that blood pressure. Which benzodiazepine should you use and how should you use it? You use whatever benzodiazepine you have and that you like to use. There is no data indicating that there is any superiority of one benzo over the other, so use what you have. If you ask the toxicologists, they'll say theoretically diazepam makes some sense because it's pretty rapid in onset, pretty easily titratable. That's fine. Diazepam, if you can choose, I think it's a good place to start. You want to dose it fairly aggressively. You start with 5 to 10 milligrams IV, pretty decent dose, but you keep going. Every 3 to 5 minutes, that dose gets repeated until you've achieved the desired clinical effect. And there are descriptions of patients getting massive doses of diazepam, up to 1 milligram per kilogram. So that's 100 milligrams of diazepam for a 220-pound person. I've never had to give a dose that big, but it's out there. It occurs. Sometimes you do have to use pretty big doses. Don't be afraid. Obviously, watch your patient for oversedation, but sometimes you'll have to use big doses in these patients. And then nitroglycerin, I mentioned a moment ago, it's going to be an important part of our therapy as well. It does some good things. Again, don't have great patient-oriented data, but we know that it's going to decrease the patient's pain, it's going to bring down their blood pressure, and nitroglycerin is one of those drugs that in the cath lab has been demonstrated to reduce coronary artery vasospasm. So it's a very appealing drug as well. So if a patient comes in with bad cocaine chest pain, your question might be, well, what do I do? Do I give them benzos? Do I give them nitroglycerin? Or do I just go ahead and give both of those things? Well, this has been looked at. It's an older study from back in 2000, and it was a randomized controlled trial, although it was a very small one, only 40 patients. And they looked at patients with cocaine-associated acute coronary syndromes and randomized them to receive either diazepam, pretty good dose, 5 milligrams every 5 minutes for 3 doses, or nitroglycerin, again, standard dose, 1 tablet, sublingual, every 5 minutes for 3 minutes, or they got both. There wasn't a placebo arm in this study, so it's just these 3 arms. What they found, interestingly, is no difference. Didn't matter. You get benzos, cool. You get nitro, cool. You get both, that's fine too. In terms of pain relief, decrease in heart rate, and decrease in blood pressure, there didn't seem to be a difference between these strategies. So what do you do? This, to me, is one of those classic sauce and spice situations. So your sauce is like the main part of your recipe. That's what's going to do most of the heavy lifting. It's the main part of the meal. It's what gives you most of your flavor. But sometimes you have a sauce that is doing okay, but you want to kick it up a little bit. So you sprinkle just a little bit of spice to kind of add to the effect of it. Same idea. This comes up in many different clinical scenarios. I think this is a classic one. I have a patient with cocaine chest pain. I've got benzos. I've got nitrates. I have to decide which is my sauce and then which is going to be my spice. So let me give you an example. It depends on the patient. So if I have a patient that comes in and they have just used cocaine and they're complaining of 10 out of 10 chest pain, but they are out of control. They are pulling off their leads. They're trying to take their IV out. They're using incredibly colorful language to cuss out the doctors and nurses. And they're also complaining this really bad chest pain. What am I going to go to? Well, Benzos clearly in that patient. He has a high degree of psychomotor agitation. Nitroglycerin is not going to do much for that. I need to bring things down a little bit. So Benzos are my sauce. Now, let's say I titrate a few doses of diazepam for this guy, and he's chill now. He's cooperating. Psychomotor agitation's better. He's cooperative. And he's still saying, I've still got 9 out of 10 chest pain. His blood pressure's still 190. I may sprinkle a little nitroglycerin onto that benzodiazepine sauce. Now, take another patient that comes in who is not really having any agitation at all, and say this is a person who's got known coronary disease. Like, oh, I've got 5 stents in my heart, and I know I'm not supposed to do cocaine, but I used cocaine, and then I did it. Now I'm having this bad chest pain. Well, and you look, and their blood pressure's through the roof. I'm probably going to use nitroglycerin as my sauce. I'm going to start with that. If I give him a few doses of nitroglycerin and he's still got a high blood pressure, still having some discomfort, then I'll sprinkle in a little benzodiazepine spice. So you have to individually tailor it to the patient that's in front of you. But they're both effective medications. So just based on the treatments we've talked about so far, we've really attacked the different areas of the pathophysiology of cocaine-associated acute coronary syndromes. Nitroglycerin to decrease that coronary artery vasospasm. Hypercoagulability has been addressed by giving aspirin to some degree. And then the increased myocardial oxygen demand, we've given them benzos to blunt that sympathetic surge. We've given them nitroglycerin to bring down their blood pressure a little bit as well. And most of the time, that will be all you need to do. But there are those patients who are recalcitrant to those treatments, and you're going to have to throw in the kitchen sink. You've got to come up with some other things. So there are a few other things that we can use as second and third line therapies. Morphine, for example. This is another medication that's been shown to have beneficial effects on coronary artery vasospasm. It's going to bring down their pain. It's going to lower their blood pressure. You have to be a little careful with this one because usually you've loaded this patient with benzos before you've gotten to this point. So you might run into a little trouble with over-sedation. But morphine's a reasonable drug to use to help with that pain, get that patient slowed down a little bit. Calcium channel blockers. And here I'm talking about the non-dihydropyridine calcium channel blockers. So I'm talking about things like diltiazem or verapamil. Well studied in this group, bring down the blood pressure, bring down the heart rate, probably have a beneficial effect in terms of coronary vasospasm as well. Calcium channel blockers are appealing here. And then there's phentolamine. So this is a great drug to use. Remember, phentolamine is a pure alpha antagonist, so it's going to decrease vasospasm both peripherally and of the coronary artery, so very appealing. If you ask some toxicologists, they say it should be the first-line medication for elevated blood pressure due to cocaine intoxication. That may be reasonable. The fact of the matter is, though, most of us don't really use this very often, and so we're probably not going to reach for this first. We may or may not have it in our PICSs. Our nurses may or may not be comfortable dosing it or giving it. So for most of it's going to be relegated to a third-line medicine, but it's reasonable. So I haven't talked about one, and that's beta blockers. What about beta blockers? Ton of confusion here. We all were taught at some point that these should never be given to patients with cocaine chest pain. And I remember when I learned this, literally day one, internship, first patient, still remember it, room 12. You come in, this is many, many years ago. You come in, you want to make that good impression. I go, I see the patient. I think I get a pretty good history. I do a good physical. My attending that day happened to be the toxicology fellow who was moonlighting as the attending in the emergency department. I walk out of the room. He's standing behind the curtain where he was listening to me, and he's like, all right, what do you want to do, doctor? And so I go through this list of things. He goes, what about that heart rate and blood pressure? I'm like, heart rate's up, blood pressure's up. I suppose we ought to give him some beta blocker. And he's like, do you want to kill him? And so that has always stuck with me that this is a bad thing. And I think we've all been taught that. But then we'll hear these like studies or these opinion pieces that say, you know what, it's probably fine. So what is the answer here? It's not a clear one, but let me go through with you what we know. So let's start by talking about the pharmacology here. So what happens when we give a beta blocker? So a patient does cocaine, and they are in an adrenergically stimulated state. They're stimulating lots of different receptors. Beta 1, going to give you increased heart rate and contractility. Beta 2, somewhat paradoxically, is going to give you vasodilation. Remember, this is a smooth muscle relaxant. That's why we give albuterol for asthma to relax those smooth muscles in those bronchioles. Well, in the vessels, it does the same thing. So you actually get a little vasodilation from beta 2 stimulation. And then your alpha agonism is going to give you significant vasoconstriction. So this sets up a little bit of a balance here between alpha-mediated vasoconstriction and beta-2-mediated vasodilation. But make no mistake, alpha is winning this battle. You get net vasoconstriction, but it is being mitigated to some degree by beta-2-mediated vasodilation. So we give a beta blocker, and look what happens. So yes, we knock out beta-1, we bring down the heart rate, that's good. We maybe make the heart work a little less hard, that's probably good. But we knock out beta-2. So this balance that we had down here between alpha vasoconstriction and beta-2 vasodilation is now completely in the favor of alpha. So it gives us that so-called alpha-mediated unopposed effect, or unopposed vasoconstriction due to alpha stimulation in the setting of given beta blocker. So the concerns here are real, that this could make blood pressure go up because you're going to get more peripheral vasoconstriction, and could exacerbate the constriction of the coronary arteries due to the cocaine effect. Does this happen? Yes, in the cath lab. If you give a patient cocaine, that artery goes down a little bit, give them some propranolol, it gets worse. Is that important? That I don't know, but it does make that vasoconstriction worse. So does any of this have any relevance for any important clinical outcome that we're looking at? It's one thing to say it has this physiologic effect, but does it matter? Well, the studies here are a little bit conflicting, and I will tell you, there really is not much good data. There's not randomized controlled data. There's a study we're going to talk about in a second, but for the most part, this has been looked at in a retrospective manner, in a case cohort manner. We don't have solid data. I will say this. There's no convincing evidence that cocaine being treated with beta blockers causes bad things to happen. There's no convincing evidence of that. But the data is just not robust enough to say convincingly that it's safe either. So we're not going to have a nice, tidy answer on this one. There was a meta-analysis published not long ago that said, hey, we can't really find any bad effect. But again, it was relying on some subpar kinds of studies. Now, I know what you're thinking. You're saying, well, not all beta blockers are the same. Or what about labetalol? Because that one seems like it would really work here because it's a beta blocker, but it's also an alpha blocker. True, but you have to remember that it's not called alphalol for a reason. Make no mistake, labetalol is a beta blocker. It has a little bit of alpha effect, but the beta blocking effect is much more profound. So how does it do in clinical practice? So this is actually one of those areas where it's a randomized controlled trial, 90-patient randomized controlled trial. They received, in cocaine chest pain patients received either labetalol or diltiazem. And they found really it didn't matter. In terms of heart rate decrease, blood pressure decrease, clinical outcomes, all the same whether they got labetalol or diltiazem. So from this study, it would seem reasonable to give labetalol. Here's my bottom line on this. I don't feel compelled to give beta blockers. Why would I? Again, 20 years ago, we were giving beta blockers to everybody we thought might have an acute coronary syndrome in the emergency department. We don't do that anymore. It doesn't seem to be beneficial in that very early phase. So it's not part of our normal practice. So we're not compelled from that reason. Also, I don't feel compelled to give it to get their heart rate and blood pressure down. Because we just talked about all these different drugs I have to use. I've got benzos, I've got nitrates, I've got calcium channel blockers, I've got phentolamine, I can give them morphine. I can give all of these things to have that desired effect of decreasing their pain, decreasing their heart rate, decreasing their blood pressure. I don't need beta blockers to do that. It's not like it's the only thing I have in my armamentarium. So I have a situation where there's no clear benefit. Maybe or maybe not there's a risk of harm. Probably not, but we don't know for sure. So why would I use the drug where there's a question? If you have a patient, this is a very pragmatic way of looking at things, but if you have a patient and they have an acute coronary syndrome due to cocaine use, and that patient then has a bad outcome, and you didn't give them a beta blocker, no one in the world is going to question that. No one is ever going to come to you and say, you should have given them a beta blocker, because it's generally accepted that we avoid these medications in patients with cocaine chest pain. So you'll never be faulted for not giving it. If the opposite were true, someone, I'm not saying you caused the patient harm, but someone could question why you gave beta blockers to that patient. So why put yourself in that situation? We've got lots of other medications we use. So that's my bottom line. Don't use them. You don't really need to. If you're going to use them, labetalol is probably the one to use because it makes some sense physiologically and pharmacologically, and there's a little bit of data to say that it's safe. So summing up cocaine chest pain. Appreciate the risk, 5% rule-in rate for myocardial infarction. Remember our two different patients, young healthy person, first-time cocaine user versus the middle-aged chronic user. They demand different workups. Rapid rule out and plus or minus stress is reasonable. That first patient could probably be discharged home after a couple of negative troponins if they're doing well. For treatment, benzodiazepines are going to be a cornerstone, and probably avoid beta blockers. Let's talk about some other drugs. Let's talk about the amphetamines, similar in many ways to cocaine. Now remember, amphetamines is a class of drug that includes many different drugs that we might see people abusing. So everything from methamphetamine to the designer drugs like ecstasy and Eve, to even things like the bath salts, the synthetic cathinones, would fall under the class of amphetamines. These all act differently, and they all have different potential cardiovascular effects. So these drugs work in a way that is similar to cocaine in that they cause an adrenergic excess, but they do it a little bit differently. Remember, cocaine blocked reuptake of norepinephrine. Amphetamines stimulate the release of monoamine neurotransmitters, so things like norepinephrine, serotonin, and dopamine. They're going to, each drug, though, do this in a slightly different way. Some are going to stimulate the release of one of these more than the others. And based on that pattern of differential stimulation of those different neurotransmitters, we can anticipate what the adverse effects of these drugs will be. So let's take, for example, ecstasy. We don't see a lot of ecstasy-related chest pain in the emergency department. It can happen, and ecstasy has been associated with acute coronary syndromes, but it's less common, and that's explained by its pattern of neurotransmitter stimulation or release stimulation. So it heavily releases dopamine and serotonin. So serotonin is going to give you some mood changes. This is why ecstasy is the happy drug, the love drug. It's a surge of serotonin that makes people feel good. You're going to get a surge of dopamine, so they get that euphoric effect. They get locomotor type effects. This is why ecstasy patients often have that pacifier in, because they get that tooth-grinding bruxism as a dopamine effect. The effect of stimulation of release of norepinephrine is much less. So they tend not to get as much of that vasospasm, elevated blood pressure, elevated heart rate. So it seems to be, and this seems to bear out in the literature, this is a lower risk drug from a cardiovascular standpoint. Not zero risk, but lower risk than something like methamphetamine, which is predominantly a stimulator of norepinephrine release. A little bit of serotonin, a little bit of dopamine, but predominantly norepinephrine. So you end up with more epinephrine at the synapse, which is exactly what you end up with cocaine, just by a slightly different mechanism. So methamphetamine can really be thought of in terms of its ability to cause acute coronary syndromes. It's much of a cocaine-like drug. Some differences, but they have largely the same effect. Cardiovascular complications, when people die of methamphetamine toxicity, it is often due to a cardiovascular complication. So how big is the risk? I will say that methamphetamine chest pain, methamphetamine acute coronary syndromes, less well studied by a long shot than cocaine-associated chest pain and cocaine-associated coronary syndrome. So we don't hear as much about this or maybe think about this as much, but we should. So we don't have great data from the emergency department setting, but here is a long-term risk study. So this study looked at patients. They compared methamphetamine users to cocaine users to patients who used neither. And they followed them over a long-term period to say, hey, what is the risk of that patient having an acute myocardial infarction? And both the cocaine and methamphetamine groups had a higher risk than people who did neither of those drugs, not surprisingly. I think a lot of people would be surprised to hear that methamphetamine was actually a little bit worse in this study than cocaine. Not by a lot. Is it really that much worse? Maybe not. But I think we have to think about it as being just as bad as cocaine in terms of its ability to cause an acute coronary syndrome. So its cardiotoxicity is generally similar to cocaine. I think it's important for us as emergency physicians to do a couple things. One is appreciate the risk. We would do the serial troponins for the cocaine chest pain. We would consider admitting the high-risk ones. We would treat them aggressively. Do all that stuff for amphetamine as well. The risk seems to be just as bad as cocaine. Treatment's going to be very similar. We're going to use benzodiazepines. We're going to use other standard therapies to bring down their heart rate, blood pressure, treat their acute coronary syndrome. And also, like cocaine, we ought to use some caution with beta blockers in this setting. All right, last thing I'm going to talk about is opioids. And this may seem like an odd class of medications to bring up in a talk about the cardiovascular complications of street drugs. Because, yes, opioids kill people. We all see that sadly every day. But they don't usually do it by having cardiotoxic effects. They make a patient stop breathing, right? Well, there is one thing that I just want to point out because it's important and it's something that you need to be aware of. And that is the fact that some opioids will cause a significant increase in the QT interval, leading to potentially ventricular dysrhythmias. And if you only remember one drug that does this, methadone is the one to remember. We're seeing more and more patients on medically assisted therapy for chronic opioid addiction. Now, we're seeing a lot of patients on buprenorphine, and we're moving in that direction. But I still see, certainly in my practice, quite a few patients that are on methadone maintenance therapy. Methadone can cause substantial increase in the QT interval. And yes, we always worry about patients who are things like methadone, that they're taking these in excess, and maybe that's causing a little bit of problem. Methadone is unique in that it can cause significant QT prolongation at therapeutic doses. So remember this the next time that you see a methadone patient that comes in post-arrest. Maybe it was a dysrhythmia due to QT prolongation. Get a quick EKG and look at that QT. Remember it in the patient that presents with syncope or the patient that presents with palpitations. This is something you need to look for on your EKG and may be a methadone effect. Other drugs will do this as well in the opiate class, but none to the extent that methadone does it. Let's talk about a couple of them that might be of interest to us. Fentanyl, well described that it can prolong QT interval. We may have never heard of this before, and it's for good reason. It doesn't do it in the therapeutic doses that we use. Fentanyl prolongation of QT is seen in the anesthesia literature using very large doses like 5 micrograms per kilogram, much higher doses than we would typically use for analgesia in the emergency department. So it's generally not going to be a problem. And I would also add on to that it's never really been demonstrated to cause a dysrhythmia. It prolongs the QT, but there aren't any cases of it actually causing a ventricular dysrhythmia. The reason I point this out is, and I'm not seeing anything on the written on this in the literature, but this is a drug of abuse now. And it's becoming one of the predominant drugs of abuse. It's become this huge problem, and patients are taking who knows what dose of this recreationally or even unintentionally, thinking it's heroin. This is something for us to think about when we see those opiate overdoses now that could have potentially had a massive dose of fentanyl. Reasonable to get an EKG on that patient just to look at that QT interval. Another one that's interesting as well is lowly old loperamide, the over-the-counter opiate, right? It's the anti-diarrheal that you can buy at the drugstore. It has an opiate effect. Now, at normal therapeutic doses, it's typically not addictive. It typically doesn't cause a euphoric effect. It just slows down your intestines, helps your diarrhea. But in taken in overdose, it can cause some problems. And this is a drug that is sometimes taken in overdose by chronic opiate users. If they are coming down off of their opiate, if they're withdrawing because they lost access to the drug or they just decided to stop taking it or whatever, they will take this medication sometimes. One, it helps the symptoms of opiate. We sometimes give it for opiate withdrawal, right? It helps with one of the major symptoms, that's having diarrhea. But if it's taken in large enough doses, it can start to have some of that euphoric effect. And this is a medication that people have incredibly easy access for. I could go down to Costco right now with a $20 bill and buy a 5-gallon bucket of loperamide. It's not hard to get large amounts of this. And so patients will take very large amounts, and at large doses, it too can cause substantial QT prolongation. And there are a couple of great cases in the literature of patients suffering a cardiac arrest due to ventricular dysrhythmia from the QT prolongation from a massive overdose of this easily obtainable drug, loperamide. Not something you're going to see commonly, but something to keep your eye out for. Well, we have talked about a variety of drugs today: cocaine, the amphetamines, even the opiates, street drugs that can have a tremendous cardiotoxic effect. We need to be vigilant, and we need to know how to handle these emergencies when they arise, and when we take care of them in the emergency department. It's been a pleasure speaking with you today. Thanks very much for your attention.